but I'm going to turn it over to Dr. Beck to share all of his wonderful perspectives and experiences. Thank you for joining us and taking your time today.
Thank you, Amy. My pleasure. I see you got my mom's email. You could leave a lot of that stuff out. She probably has other things she could add. Usually, one of the challenges when we do Zoom kind of things is I like to walk about and have a show of hands how many folks were really aware of the fact that there are dire consequences with regards to the induction of Suboxone in our patients that are attempting to recover along their journey. So I'll basically try to address 4 areas. Next slide, please, Carrie. Next slide. So there obviously are 3 FDA-approved drugs for, well, I'm so old, we call it medication-assisted treatment. Now we call it medication for opioid use disorder. The impact on oral health has been extremely overlooked. We began researching this about a decade ago and developed some dental pre-habilitation, peri-habilitation, and post-habilitation protocols. I think what's most impactful for most of the audience today is a lot of these dental interventions are easily mastered. They don't require a lot of skill sets. And by the way, they're reimbursable by Medicare and Medicaid when provided by a medical provider. So in our model, this is not exclusively services provided by dental. Medical assistants and nurses can provide the same and really do a tremendous amount of service as well. And over the years, we've gained some experience, and I'll share that with you with regards to a dental pre-habilitation program. So we have modeled this program pretty identically to other dental clearance protocols, which have become the benchmarks of care with interprofessional education collaboration over the last decade or so. So patients undergoing bariatric surgery, orthopedic surgery, cardiovascular valve surgery, head, neck, rad onc, all of those require a dental screening to make certain that they're a candidate to proceed with the invasive care. And the same with regards to MAT. Next slide, please. This slide, we actually incorporate one of our venues of care at my residency, Bon Secours Mercy Health, St. E's Youngstown. We have 3 mobile dental vans, and most of us recognize this picture, the 2 overdosed grandparents and the child in the back seat. I include this because these were actually our patients down in East Liverpool that we cared for their family and their dental needs, and obviously pretty compelling. Next slide. So the FDA approved methadone with the oral route of administration. That generally is not terribly challenging. Buprenorphine, it's interesting. We had an addictionologist who just retired at our facility, and buprenorphine evidently is extremely popular in the European markets. It does not have a pH issue that causes problems. And then obviously the most popular method of induction with these folks is Suboxone, which is a combination of buprenorphine and naloxone. We'll talk a little bit about the rationale for that combination, obviously to attempt to prevent illicit diversion of the drug and the consequences of the oral route of administration of something that has a pH of battery acid. Next slide. Most of these administrative routes, of course, are oral. Methadone, because it's swallowed quickly and doesn't stay around, is not a topic of this lecture. Buprenorphine, the sublingual tablet, might be something that we would want to consider for lots of reasons. It would take out a tremendous amount of the dental implications. And Suboxone, as we take these individuals, and as all of you are very familiar, unfortunately, this population cohort presents with severe dental disease and devastation, a lot of broken teeth, active, decayed teeth. And remember, dental decay is infectious, contagious, and transmissible. and they come in with an extremely dry mouth, and all the beneficial effects of saliva are removed. And then we tell the patient to please dissolve this film in the oral cavity for 15 to 30 minutes with a pH of about 2.8. And then we tell them no food or liquids for 30 minutes. So we are creating the perfect storm with regards to promoting and enhancing the dental decay. Next slide, please. Without question, we know that this tends to be the most effective plan of care with assisting the patients with regards to their journey in recovery. Unfortunately, these patients already have dental decay. The Suboxone promotes that situation, and very unfortunately, dental decay cannot arrest itself, and as it proceeds to dental abscesses, acute pain, and the need to seek relief from that pain, and unfortunately, maybe a reintroduction to opioids by a novel or novice provider. Next slide, please. So recovery patients, we all know they have severe xerostomia, dry mouth, and the salivary functions cannot be overestimated. The lubrication, dentition, and oral tissues. And one of the important features that we don't think about very often is salivary lubrication of our taste buds. As salivary lubrication of our taste buds enhances our ability to taste the food and enjoy it in a much better way. Because they have an extremely dry mouth, they present with cravings for extremely high sugar and carbohydrate rich foods, because those are the ones that are best able to stimulate the taste buds. And the euphemism has become kind of common. We talk about Mountain Dew mouth, and we'll talk about Mountain Dew because it has a pH almost as devastating as Suboxone. So the salivary functions, lubrication, both of the dentition, oral tissue, it buffers the acid, provides protective biofilm coating to the teeth so that the decay can't progress. And as I suggested, not only does it enhance taste, but it's important with regards to mastication and digestion. And so if we're hoping that our patients will have a high protein, fiber-rich vegetable diet, but yet the mastication and digestion is prohibited or compromised, those folks are less likely to take that route and more likely to have their Mountain Dew, Skittles, and potato chips. Next slide. So Suboxone buccal films, a pH about 3.4, and if that weren't bad enough, then we add sugar to it. So now we have sugar to flavor it and a pH of 3.4. And if you were to want to conduct research on promoting dental caries, those are the two things that you would make sure that would happen. And then, of course, the mode of induction and the mode of post-induction instructions further exacerbates the problem. Next slide, let's take a look at what Suboxone really is and why it happens this way. So in 2015, then buprenorphine was approved for sublingual administration to treat opioid use disorder. Now, the interesting thing about a buprenorphine sublingual tablet is, I checked with our pharmacist, it cost our system about 14 cents to purchase, and actually can be placed under the tongue and has very little effect with regards to acidity and dental devastation. Conversely, the combination of buprenorphine and naloxone has a pH of about 3.4, as we mentioned, and it cannot be administered any other way but with that film. And with regards to that situation, it costs our system $1.14. So it's 10 times more expensive and comes with lots of devastation. So I'm not preaching, I don't want to attempt to preach to the choir. Everybody on this call probably knows far more about buprenorphine and naloxone than do I, but I guess my challenge would be, why don't we maybe consider the European method with pure buprenorphine and eliminate Suboxone? It's cheaper, equally effective, and has no dental side effects. Next slide. So how's Suboxone taken? It's either sublingual or buccal. And as we mentioned, 30 minutes. It looks a lot, if you remember, in the very old days, we actually had Listerine came out with this vehicle. In fact, I think they might be the first company that actually developed that film vehicle to deliver a pharmaceutical modality. And so that's been adapted with regards to the Suboxone Trexon combination. Next slide. So Suboxone, when it becomes acidic and goes into the mouth, as soon as it's dissolved in the mouth in water, and as we mentioned, there's not a lot of free saliva available to begin to buffer that 3.4 pH. We do know that the bioavailability of the Suboxone is compromised, so patients receive those very strict instructions. And I think this is the third time I said it because kind of that important is that they're told to dissolve it in their mouth for 30 minutes, and then they're told not to have anything in their mouth for 30 minutes thereafter so that they can maximize the uptake. And that has a whole bunch to do, as we mentioned, the Mountain Dew effect, as we call it, where you see individuals carrying their bottle of Mountain Dew to their dental appointments or their behavioral health appointments worth yet. Next slide. So dental decay 101. Don't want to be rocket science on this, but it's important that we understand the science of this. Most of the time when we took high school health class, we were under the impression that the carbohydrate foods that we ate combined with the bacteria in our mouth, and those two substances produce something that we call dental plaque. And some of us on here might be old enough to remember when we chewed up those red tablets and looked at the teeth and saw all the red tablet disclosing solution, which identified where the plaque was. We now understand it's far more sophisticated than that. The dental plaque is not a plaque at all. It's a very sophisticated biofilm. But what ends up happening is three things. The biofilm, as it sits on the tooth, it protects the bacteria that actually engulf themselves within this bacteria. So the biofilm is a slimy, gooey substance, not unique to teeth. Biofilms are all over our bodies and actually very impactful in chronic disease processes. But what the biofilm does is protect the bacteria that are in there. The bacteria that are in our mouth then are actually not subject to our normal immune system. And if we have a lack of saliva in a lower pH, what happens is the good bacteria in our mouth that survive at a pH of about 6 to 7, which is where we would really like our mouth pH to be, those bacteria die off at a pH of 2, meaning that the acidophilic bacteria, those that love the acidic environment, unfortunately also tend to be the acidogenic bacteria, meaning those are the ones that produce the acid that cause decay. So it becomes a snowball rolling down the hill effect once we begin this process, because as the pH of the mouth is continually lowered and remains such, what ends up happening is the good bacteria, so to speak, die off, allowing the bad bacteria, those acidophilic bacteria that love it in this environment, they produce acidogenic products, and now we have a whole bunch more dental devastation occurring. Next slide. This slide becomes complicated, but basically what we want to demonstrate here is there are primary contributing factors and secondary contributing factors. And basically salivary flow, the pH, are what we talked about. And some of the modifying factors we'll talk about is fluoride use, and fluoride can help us tremendously. There's two modalities in which, as healthcare providers, you can help your patients tremendously. It's as simple as taking a paintbrush and applying it to the teeth. The teeth do not need to be cleaned or disinfected with these particular objects. And secondary modifying factors, we know this: education, socioeconomic status, lifestyle, and all of those contribute. What is the diet? What's the sugar exposure? And what's the dental hygiene practices, not only on a daily basis, but as a professional intervention basis. So what we have, a lot of combinations, social determinants of health, along with a lot of pre-existing conditions. And so that creates a perfect storm for dental decay to proceed. Next slide. So we have the kind of dynamic battle between the acidic erosion of the teeth and the sucking out of the calcium and phosphate ions. And if we were to have saliva, saliva acts as a reservoir in a pool to keep phosphate, fluoride, and calcium ions to help replace them. So if you have a nice healthy environment with a pH of 6 or 7, and you have a normal salivary flow, that enables the patient to remineralize their teeth at a rate that should exceed that of being demineralized. So dental decay is a dynamic and ongoing process, and most of us don't really realize that fact until the demineralization far exceeds the remineralization, and we become symptomatic. Next slide, and this is where things become kind of impactful. So next slide, please. So we talked about the critical pH. One of the things that's important that we don't often think about, and there is a new dental disease that we've identified in the last 10 years called sipping caries, S-I-P-P-I-N-G-S. In other words, we sip. And so we began to notice in the dental profession, students that were in our practices for 18 years and very well maintained would go off to college, and they would come back for their checkups and have 3 or 4 new dental carious lesions. And basically, we did some research projects across our study club with this, and we're perplexed to find out that, were we missing these on the radiographs? We reviewed radiographs. What was going on when they went away to college that was different than when they were home? So we asked the obvious first question: help us understand how your consumption of carbohydrates has changed while you're at college. And so said, how many soda pops do you drink a day? And they said, well, just one. Oh, just one? Okay. And so we moved on, not asking the next question that we should have. And the next question that we should have is, so you have your soda pop sitting at your laptop and you're studying, how long does it take you to consume that can? And the answer generally comes back 1 to 2 to 3 hours. And we call that sipping caries. So if you take a look at the illustration, what happens in your mouth when something enters it, the pH will actually drop from normal resting of 6.5 to 7, all the way down to about 4.5. Now, 4.5, if it stays there for prolonged periods of time, that is the pH at which irreversible dental disease occurs. At 5.5, that's the red line demonstrating that's where reversible dental disease occurs. So at 5.5 is where you start to find the threshold upon which more demineralization occurs relative to remineralization. So you can see that what begins to happen is if you take a sip of your drink and then 10 minutes later take another sip, well, you can see that it takes 15 to 20 minutes for the pH to return to normal. So what begins to happen is your pH drops from 7 to 4, and then it begins to climb back to normal. But now you introduce another sip, and it goes from 4 down to 3.8, and then it begins to recover again. And so what begins to happen is you now have a situation where it's impossible for the pH to recover. And then the very same scenario that we discussed with our recovery patients occurs with our college patients. So dental sipping caries becomes significant. Next slide, please. So I appreciate the invitation today, because what we've learned, obviously medical and dental knowledge with regards to the severity and the impact on this is severely lacking. We know we know without question that individuals that are induced on Suboxone without any dental intervention, on average, will lose 20 teeth during the first 300 days of their induction. 20 teeth. Now, and if you look on the blogs, and I'm not a big blogger, but when I do my research, there's lots of information with this. This scenario is not at all unlike a very similar scenario that's experienced by our patients that are undergoing bariatric interventions. So patients that undergo bariatric interventions actually end up in a very similar situation by very different mechanisms. So the mechanism here of acid introduction is Suboxone film. But when patients get a bariatric intervention, the pyloric sphincter becomes incompetent, and they either will have a lot of vomiting, much as a expectant mom does with morning sickness, or if they don't have the vomiting, worse yet, they'll have gaseous reflux. And so what begins to happen is the hydrochloric acid in the stomach has a pH of 2. That's far worse than the pH of 3.4. So now you have an environment in the mouth that's created gaseously. So that pH is no longer 6 or 7. That pH is down to 2. And again, the acidophilic bacteria tend to be the acidogenic bacteria. So we know what we began to learn from bariatric interventions. It is exactly the same mechanism, different introduction and maintenance of acid. So we need to establish an evidence-based protocol that all of us can share to prevent this information with regards to, number one, let's arrest dental decay, and we'll share with you a very simple method to do so. If I forget, sometimes I do, remind me to talk about the terrible brown staining that will occur on your countertops, not in the patient. We have that all over our dental clinic. It's inconsequential, but the silver diamine fluoride will do such. So there are some great attempts, to actually manage these individuals. The challenge is dental decay is infectious, contagious, and transmissible. So that if I have a patient referred from you to our dental clinic and they need 9 fillings, I either have to do all those 9 fillings the same day, or if I do 2 and then they come back, I have news for you. The 2 that I filled will be okay, but they'll have 2 more additional ones because they self-inoculate. So what we need to do is find a way to arrest the dental decay, and we do have that. So next slide. Identifying these challenges way back when, in about a decade ago, it took until 2022 before the FDA actually released the drug safety report. Dental problems, including tooth decay, cavities, oral infection, loss of teeth, can be serious and have been reported even in patients with no history of dental issues. That's the take-home lesson there. And the reason for that is, as we have alluded to, the bacterial populations and microflora are significantly impacted by the acidic environment, and that's what actually happens as a result. So we're after lunch, so we can show some of these pictures, but I'm sure you guys have all experienced this. Next slide. So this is kind of what happens. And so the dental teeth, they do become brittle and break. And so what we find, we're familiar with this in heroin use. Now, the heroin use, remember, this is a whole storm of behaviors and activities that contribute, because these individuals are carrying around their Mountain Dew, they're consuming Skittles, high carbohydrate intake, and obviously oral hygiene is completely absent. Next slide, probably more popular use of drug is we know about meth mouth. Now, meth mouth becomes a perfect storm for a couple of other reasons. As meth is cooked, as they talk about on the street, when meth is cooked, it has an extremely low pH and actually a very low residual pH. So meth mouth is mirrors quite a bit like Suboxone. And again, all of the situation remains the same. Next slide. And we do know that a lot of our patients will be HIV or Hep positive. This is an individual that actually had great hygiene, but what they actually did demonstrate is a HIV Kaposi sarcoma lesion there. Next slide. We do know that the patients, when the oral environment gets changed, so the bacteria are altered, so then we do have a significant amount of yeast in our mouth, Candida, and the oral candidiasis from Suboxone can become great. Now, we're familiar with candidiasis, thrush in babies, or diaper rash are both the same disease entity. Those are both candidiasis, one from the rectal area, the other from the oral cavity. We're familiar with this looking like the cottage cheese where we can go in and scrape this off. But there are actually many other forms of oral candidiasis where the mouth is just jet red and burns. So if your individuals are complaining about burning mouth and you look in and say, well, there's no candidiasis. If their mouth is jet red, magenta, they do have what's called acute atrophic candidiasis. It's not pseudomembranous. And in this behavioral health population, they generally rarely exhibit pseudomembranous. They'll exhibit acute atrophic, and I apologize, the picture I forgot to put in on that. But if they complain of a burning mouth and we want to get them to a dentist, we can treat that with a myriad of antifungal medications. Next slide. So as we continue along this journey, and the sad part is I didn't have to go to the internet to get these slides. These are from our dental clinic at St. Elizabeth Youngstown Hospital. This particular patient, one of the things we reached out in our region, I'll give a big shout out to Judge Durkin and his drug court. He has one of the longest running drug courts. But as we began our program, it dawned on me that, hey, the patients in his drug court are all on Suboxone. And, you know, I reached out and said, hey, Judge Durkin, how about we'll be happy to accept any of the patients in your drug court that don't otherwise have dental care to actually assist them in their dental needs so that we don't create a situation where they would be in pain, abscess infection, and then seeking relief from their pain, either with opioids by a licit prescriber or worse yet, from an illicit situation. Next slide. So as I mentioned, the teeth do become brittle. The kind of classic sign is these gum line areas that are dark. As those gum line, the reason they're dark at that point is because that's where the plaque biofilm generally sits. It's not being cleaned. And it's much like you would chop down a tree. You chop down the tree at the bottom, you create a big fulcrum and a weakness, and then as they bite on the top of the tooth, it shears off. On the bottom, by the tooth is completely broken off, you can see a pustule. We call that a fistulous tract or a perilous. So that whole gum enlargement is a tremendous site of purulent exudates of pus, and that patient's in severe pain, and so they need relief from that situation. And that's either an extraction or otherwise. Again, next slide. And again, don't need to be making a radiologist out of you, but these are patients that actually are from our dental clinic in Youngstown, Ohio. You can take a look and see all the root tips here, a couple teeth that were previously repaired, and all of the abscesses in the jawbone. So number one, these individuals couldn't eat protein and vegetables if you really wanted them to. And so what we need to do in these individuals is pre-habilitate them, take out all of the teeth that we think are hopeless or potentially a threat to them getting an infection within 12 months of their induction, and then restoring them, getting them some partials or dentures so they can better chew. And we've worked with the Ohio Department of Health, and our Ohio Department of Health with their safety net clinics now has a program where 25% of the monies that the safety net people get for providing care can be used toward fabricating dentures for these individuals if they're not on Medicaid. Medicaid will pay for dentures on Medicaid, but unfortunately, as we know, a lot of these folks are middle class or lower middle class and just in the throes of addiction, so they don't qualify for Medicaid. And so what ends up happening is they are unable to get a denture otherwise. Next slide. So we can begin to see the devastation as you see the teeth, and the bite begins to shift, and it becomes a very unfavorable dental situation. Next slide. So we can see the black abscesses demonstrated in the jawbone, and these particular individuals are in a lot of pain because it's not just a tooth. It's actually it's actually osteomyelitis that begins to happen.
The turkey day.
Oh, somebody is talking right now and not muted. If everyone could just remember to mute themselves, and we'll and that way we won't interrupt Dr. Beck while he's trying to present. Thank you.
Thank you, Amy. Next slide. And so I think the next slide, you can see all of the black circles deep in the jawbone, lots of pain. So now let's get to the, no, you were good, Carrie. Next slide. Let's get to where the boots on the ground meet. So we know how and why this situation has occurred and why it might continue to occur. So what is it that we can do to help these individuals along the way? So at our facility and in the drug court, as Judge Durkin sees fit, we send our patients for a dental pre-habilitation before the patients get their first induction. I understand how critical it is that when the patient is ready, we want to meet the patient where they are and get them induced. But by the same token, we want to make sure that we don't get them back into an addiction situation by an unmonitored or uninterrupted dental situation. So we do what's called a caries risk assessment, full mouth x-rays, radiographs, dental evaluation, and gum evaluation, periodontal evaluation. We've talked almost exclusively about the teeth because of the pH, but all of the entities in the pH in the bacteria that affect the teeth are also affecting the bone holding the teeth in. Next slide. So the American Dental Association has a lot of these caries risk assessment forms. This would be more in the dental realm. I'll share with you a form that we use that you can certainly adapt into your office as well. Next slide. So what's the dental clearances look like? This is the slide. This is what we actually provide for dental management with the pre-Suboxone clearance. So it's a fairly simple screening assessment. So the patients come in our clinic, we actually have time set aside. So the cardiovascular valve clinic is, I think, Tuesday afternoons. Planned interdisciplinary diabetic clinic, I think, is Thursday. And these individuals, so we have these tracked out. One of the things that we do is, those of you from Youngstown know that Mercy Health, we just bought the old VA hospital and put $4.5 million renovating it. So we have an intensive outpatient behavioral health center down the street from our main campus that's co-located, not unintentionally, with our primary care practice and primary care family medicine practice, and our women's and child health. So they're all of those co-locations allow those folks to be in a similar situation. And we actually bring our mobile dental vans to the behavioral health site. So we can provide those screenings while the patients are there, kind of get a 2-for-1. And so basically, we decide, what we see and what needs to be done immediately, and what can be done with regards to the elective treatment after the fact. So we quantify, and the military does this, type 1, 2, and 3. So type 1 is dental health. Type 2 is dental health that would suggest that there will be no dental emergencies within 12 months. And of course, that's an educated guess, but military stands upon that. That's how they identify individual reservists for deployment. And then type 3 is there is existing dental disease, and unquestionably dental emergent situations will occur within 12 months. They need to be taken care of. So next slide. Here's our summary slide. We talked about the caries risk assessment, and you're welcome to borrow any of this, or I could send that information out with regards to what's going on. But the initial clearance, the caries risk assessment, the exam, and dental disease control. This is where we can share activities. And this is where we worked hard with advocating with our legislators. And I saw a little note about dental Medicaid. I'm glad to announce that for the first time in 23 years, yes, I said 23 years, dental Medicaid fees have increased, so that we will recognize about an 80% increase in dental Medicaid fees. Now, don't go running to your legislators, because 80% of 30% of a 23-year-old fee is not a substantial increase, but it at least is something in the right direction. So the dental disease control, some of those teeth you saw, we need to resolve the infections, extractions and root canals, restore what we can, arrest, and we'll talk about silver diamine fluoride. That's probably the most impactful modality that we have. Some of us on this might remember silver nitrate sticks. We used to take silver nitrate sticks and actually great cauterize active bleeding and active wounds. Silver nitrate sticks, if we take silver nitrate and package it with stannous fluoride, we get something called silver diamine fluoride. In a lot of third world countries in Europe, dental care consists of little more than a provider of some sort taking silver diamine fluoride and putting it on these active dental lesions. It's very simple to do. Yeah, you just apply it with a little micro brush, and it immediately arrests the decay and caries. So you can see the advantage if you have somebody that has 8 carious lesions, you paint all 8 of those, you arrest those. And if that's in a dental office, I feel good about it because I can get them back and break up their visits. But if it's in your office or a primary care office, the nurse practitioner, the medical assistant can do that. And then you can refer to the dentist to get definitive care. The important thing is you arrest the decay, stop the progression of the process, and most of the time you completely eliminate any symptoms. And then we talked about the periodontal health of the patient, gums and bone. They often need scaling and root planing as well. So those are situations that we work out with. Now, preparation for Suboxone. Individuals that have lots of decay, we actually make them custom fluoride trays. So we talked about the dynamic with regards to individuals we want to remineralize, demineralize. Well, if we can remineralize, we actually take and make them a custom tray. Oftentimes we give them fluoride to put in the tray, and they actually wear them for 20 minutes a day, so that they are jacking up tremendously the amount of fluoride available to remineralize their teeth. Fluoride is also antibacterial, and so it helps with regards to addressing the microflora agent. There are fluoride toothpaste that are prescription strength, and so we often use the fluoride toothpaste as well. Antibacterial mouth rinses, chlorhexidine. We might recognize chlorhexidine. That's what we use to scrub our hands pre-surgical. There's a 0.12% dilution that we use in the mouth, and these individuals certainly can use it where it's antimicrobial, and we can reduce the amount of bacterial involvement in populations, altering the microflora. Then zero stoma management. We used to call this artificial saliva. That doesn't sound so good because sometimes it conjures up an image of the individual going to the blood bank and giving blood, or spitting in a bottle, and now we have artificial saliva. So what we call these oral lubricants, and there's lots of them. They're very important. And then lastly, fluoride varnish. And silverdimine fluoride and fluoride varnish are both application modalities that can be addressed and provided by the medical community and reimbursed to the medical community once you get a very simple in-service. Next slide. So we have dental decay, the caries control. We want to restore active lesions, arrest them first, and we don't have to fill everything. If we arrest the small lesions, then we can get back to those at a later point in time. Periodontal control, as we suggested, deep scaling, root planing, antimicrobial agents. There are some modalities that we can put into custom trays to address periodontal situations as well, vancomycin and hydrogen peroxide. So what does the regimen look like? Next slide. So Prevident is prescription toothpaste, 5,000 parts per million. The chlorhexidine we talked about, silverdimine fluoride trays, and fluoride varnish. So if we take a look, one very significant issue is xylitol gum or xylitol mints. In the old days, xylitol used to be by prescription. So it was a prescription mint or a prescription gum. Xylitol works extremely well because it's antibacterial. And so in our centering pregnancy model, all of our moms are instructed to chew 6 to 8 sticks of xylitol gum a day. It actually inhibits bacterial replication in the expectant mother. And interestingly enough, it's vertically transmitted, so it alters the bacterial microflora of the expectant fetus. Xylitol, you can find that anywhere. I mean, the vitamin store. Don't buy it at the pharmacy. It costs a lot more, but go and get xylitol gum spry. SPRY is a common one. I was at Starbucks this morning getting my Starbucks coffee, and I looked at their mints, and their mints are xylitol. Important piece with this is that xylitol must be the primary active sugar alcohol ingredient. So Dentyne gum, they actually put a little banner on the left side of their product that says now with xylitol. That's true. It's true, but misleading. If xylitol is not the primary sugar alcohol, that ends up not being effective. So we want xylitol as primary active ingredient, and there's a plethora of those gums out there now. Oral neutralizing rinsings, there's a lot of them. There's a whole series of products called Carie Free. You can go online and look. You can go to the store and find out. Something as simple as a teaspoon of baking soda and 8 ounces of warm water will neutralize the oral pH. Interestingly enough, I think we all feel the same pain with reimbursement in the insurance industry. The insurance industry patients, if they do have third-party insurance, they'll actually pay for 3 to 4 cleanings a year, not just 2, simply because they understand the downstream savings with regards to what's going on with that. In zero stomia management, there's a whole company called Bitonte. You can go online. They make gum, oral rinses, lubricants, salients to put on, and they work out very well. one of the things that I don't think is a good idea, and I would refer this to physician, but there are medications that you can actually induce salivary production again, generally more utilized in post-rad-onc surgical and radiation procedures in patients where the pilocarpine can help stimulate saliva. The challenge with this is even though you might get an increased volume of saliva, the consistency in chemistry is definitely not the same. Next slide. So this is from the Ohio Department of Medicaid. It talks about how you can actually get reimbursed with regards to topical fluoride varnish and or silver diamine fluoride. So these are very simple applications to put on and do your patients a world of good with regards to what's going on. Next slide. So what are we doing as we are wrapping this up? Well, research-wise, we have created a program where we're actually going to take pH of the patients before administration of Suboxone and pH of their mouth after the administration of Suboxone, and then track them temporarily as they go through their process and see if we can impact that pH, and if simply awareness of this situation helps impact outcomes. Baking soda, sometimes simple is better. And again, the challenge, as we all know, is getting motivation and compliance. It has to be simple. So sometimes chewing xylitol gum is a lot simpler than rinsing your mouth with baking soda. You have to introduce back behaviors that will actually result in compliance. Next slide. So peri-habilitation, as we talked about, what do we do in the ongoing process? Well, silver diamine fluoride, fluoride varnish, prescription fluoride toothpaste, xylitol mints, oral neutralizing agents, chlorhexidine, all of the things we talked about ongoing, and this is going to be a continuum of care if they want to stay out of long-term dental disease. Next slide. So custom fluoride trays we can make. They look like athletic mouth guards. They're customized to individuals, and they can actually not only be utilized for fluoride, but we can put in other, if the patient's dental disease, we want to target the gum disease, we can put in some topical tetracycline, vancomycin, or peroxide, or a combination thereof. Next slide. So periodontally, we don't want to minimize that effect, because periodontal disease is the most ubiquitous disease on the face of the earth, and certainly affects these folks as well. The challenge with periodontal disease is it generally tends to be very asymptomatic for a very long time until deep into the progression. So we spend most of our time talking about dental disease because that's what we can actually look in the mouth and visualize as we move forward. Next slide. So as I did suggest, 3-month post-care is mandatory, not 1 month, not 3 months, not 6 months, but obviously the importance of this is being recognized by our payers. And so we actually try to get these folks on a regular interval with regards to that. Last slide, I believe, 2 more, I guess, is we have some references with regards to SAMHSA and the Suboxone medications, and then some of our references with regards to where we are. So, Carrie, I think I was just about spot on with time, and pause here and see if there's any questions, any clarifications, comments.
You were just about spot on, Dr. Beck. Thank you so much for your presentation, for sharing. As I think someone who's an ally for people who are in a lot of difficult situations in their lives. I think there's one question. I've been not able to see the chat as I was screen sharing, but I see a question from Amy there about, are Xyla melts helpful?
Exactly. Xylamelts are xylitol. So those are, any xylitol product is extremely helpful for these patients. And actually that really helps with the saliva with regards to that. Now, if you go on the internet, because if it's on the internet, you know it's true, right? So yeah, xylitol consumption will result in severe diarrhea. Takes about 1,100 sticks of gum a day to do so. So I don't think that's nearly a concern. And in fact, the fact that our OBGYN and maternal care, they encourage us to chew xylitol gum throughout the day. One of the things that we're trying to get done in our school systems is to have our children chew 6 sticks of xylitol gum a day. That's what they do in Scandinavia and have been for years with great school-based success. The challenges that we get is they're going to stick the gum under the desk. I mean, but the outcomes are, we can pass a basket. So Xylamints are great. Anything xylitol works out very well. That if you go online and go to the vitamin store, they will expound upon the therapeutic effects of xylitol for ear infections. That's way out of my realm, but I do know orally it's extremely impactful, and actually impacts via vertical transmission the fetus and the bacteria and its ability to ferment the sugars.
Interesting. I have 2 additional questions. I know we've had some comments in the chat about the Medicaid piece, or just and you also referred to this a little bit, but in your when you try to get dental clearance for patients, is that reimbursed through health insurance? How are you paying for this, the dental clearance piece, in your health system?
That's a great question, and my job's pretty easy because I work for a mission-based organization, and our mission is to take care of everyone regardless of their ability to pay, with special emphasis on the poor and underserved. And so the way my dental clinic works, I get tremendous amount of extramural funding. So I'm pretty sure I wouldn't be talking to you today if I didn't get about $2 million of extramural funding annually. Now, having said that, those 2 reimbursable procedures that we talked about, silver diamine fluoride and fluoride varnish, are reimbursable medically at a rate higher than they're reimbursable dentally. So now so those are some items that as the team leaders, you don't want to be spending your time doing that, but you can have your individual, just much like the pharmacist says, hey, are you aware? You have any questions with regards to the medication that we're providing you? Are you aware of this, and this? And, we just have a sheet that we provide for them. And you can ask them if you're interested, because these are some services that, my dental clinic is, we are 627 dentists short in the state of Ohio. I have an 8-month waiting list to get in for historically compliant patients. My safety net's not unlike lots of other ones. So there's a great need. And I think Medicaid in state of Ohio recognizes that. That's why I think they're kind of encouraging our behavioral health team to get on board with regards to providing silver diamine fluoride and fluoride varnish. And those are reimbursable. So, we're not asking, number one, you can't conduct a screening exam based upon your license, but you can do these.
So if I'm understanding you correctly, these are things that clinicians or physicians could prescribe without having to wait for the dental referral.
Exactly.
Gotcha.
Yeah,
Okay.
and that's what we're talking primary care. So if you saw a mouth like those pictures, you're doing a great service. You just dip this little brush in and paint this clear liquid on. Now, if you drop that clear liquid on a countertop, it will cauterize your countertop, so to speak. It'll be brown for the rest of the life. Nothing you can get out of it. In that silver diamine fluoride, the controversy, those who are advocate against it say, well, it turns the teeth brown. Well, weren't those teeth already brown? So that's kind of a weak situation. Now, in individuals that, like in children, this is a great, I don't have a big pediatric practice, but the children in my practice that come in that are panicked because their previous dental provider, scared the tar out of them and they still need 3 fillings to go, we paint them with this. And guess what? Most of the time, they don't even need a dental restoration. So, why put them through that? It arrests the decay and does pretty nicely with regards to that. So, the dental profession, we, as I said, we're 627 dentists short. The pandemic resulted in 24% of our workforce exiting. So, I mean, we're going to identify another need for dental, but the challenge is going to be we're not going to have enough providers presently to do so. But you might suggest in your areas, look at dental hygiene schools. There's dental hygiene colleges. There's dental assisting schools. There's dental residencies, and there's dental colleges. Well, 2 now, soon to be 3. So we have Ohio State and Case. But in Youngstown, we have Youngstown Dental Hygiene. That's Stark County. I mean, there's quite a few of these around. So I think there's a good opportunity.
Thank you. And I see we do have a couple of questions in the chat, and then I see Jessica Collier's you've had your hand up as well. So if you want to ask your question.
Yeah, I just wondered, where can we point these providers that obviously don't know these things to get them on board or to offer the services, because just telling them isn't working and they don't listen to us, no matter what research I do, no matter how much evidence I can bring them. So what do I do at 50 plus dentists to not lose every tooth in my mouth?
That's a great question, and it's that there needs to be a cultural change in dental education and dental providers, and actually that's that provided the impetus for our researching the development and sustainability of a new dental college with regards to education. But dental care is truly interdisciplinary and affects, you name a disease or an intervention, and we can talk about what the impact is on dental. And so what begins to happen is, I think we need to get the message out. I hate to say this because I'm one of those guys I used to have gray hair, now I don't have much, but what you need to get the young people that will embrace this. The new generation, I guess we call them Gen Zs now. Those are the individuals that I think you'll finally get in with. Dental societies tend to be progressive and have continuing education programs. Dental hygiene, the same, because there are, to maintain your licensure, you have to get some continued education. These are things you hate to say that because they provide a revenue stream, they're more likely to be utilized and you're more likely to engage a provider to do so. But there are revenue streams with this, and the overhead for this is not very significant. And so I would suggest we start with our local the dental society and or dental education component in your area.
Great, thank you. The next question, what is the average time from first appointment to the time of induction?
First appointment meaning dental screening?
Camille, do you want to ring in on specifically what you were referring to in your question?
Yes, from that first referral appointment.
So what we've actually created in our residency is unique because we've been doing this for about 20 years. So we created what we call protected designated slots. primarily for emergency department referrals. And then as we grew over the years, for new referrals. So we actually have weekly protected slots that you can get in within the week if you're referred. Now, you say, well, you're going to lose money if those slots remain open. No, we take care of the 30 people that walk in unannounced. So basically becomes a balance with regards to that. Now, I will have to say that it's like anything. We started out pretty robust. And then as time goes on, I'm not sure if it's provider fatigue or if it's like, hey, you got 17 minutes to be with your patient, get them, and we forget, the behavioral health provider forgets about it. In an educational institution that's mission-based, we have a little bit more time to address that. But what we're working across is introducing this in our primary care Mercy Health owned practices. And so, but again, like anything, if it doesn't become a key performance indicator or a value-based RVU, sometimes we lose sight of what we should be doing, what we could be doing, and what we won't do because of time. There was another question, was a good question I neglected. So there are limitations to sodium diamine fluoride application, primarily in children. So the size of the child, and the reason for it is not that it goes into their system, but it might actually accidentally get on the gums or actually get on the tongue. And so I think for children, it's 3 teeth per application. Remember, they only have 20 in their mouth. So hope to God they don't have more than 12 carious lesions, but that can be done. So yeah, there are some limitations, significantly less in adults. Sometime the limitation, and again, this is sad, but we're all in the same boat. Sometime the limitation simply is I only get reimbursed if I do 3 teeth per event. Well, they're sitting in the chair, traveling's a thing. You already have the room cleaned up. Let's just do one because it's the right thing to do.
Thank you. And then we have another question related to, is there a limit to the amount of SDF we can bill out per patient per appointment?
Yep, that's just what I was saying, 3 to 5 teeth, right?
3 to 5.
And that's actually on that one slide. I think it actually addresses that.
That's the minimum or the maximum?
It actually, there's no minimum. It would be a maximum. So you can do, I think it might be 5 to 6 teeth per adult, 3 to 5 per children.
And then what is the percentage of fluoride that you use in the trays?
The percentage of fluoride, it depends based upon the particular patient. So in fluoride, because all fluorides aren't the same, okay? We often talk about stannous fluoride, okay? And that's the one that we all grew up with. That's where Procter & Gamble made all their money, because Procter & Gamble, if you remember, toothpaste used to come in tin tubes. Remember the tin ointment tubes that, well, maybe some of us shouldn't, remember that. But what Procter & Gamble did was they actually were able to devise a coating, the internal side of that tin that prevented the tin from coming out of the fluoride. So any fluoride toothpaste in the world for 7 years, and we didn't care where it came from, they had to buy the tubes from P&G. So there's lots of different fluorides, and it would be specific based upon the provider. But generally speaking, like 5,000, we do like drinking water is 1 part per million of fluoride. Okay, but if you notice, the Prevident was 5,000 parts per million of stannous fluoride. And so all fluorides aren't the same. It depends on what you're attempting to address. And I think we don't want to make clinicians out of you. It took me 3 weekends to go to dental school to learn most of this stuff. So get that.
Tom had a question related to, should we formulate xylitol into the Suboxone?
That's a great question. I've asked that of our P&T team, and evidently if we were to do that, we talked about Suboxone having a very limited uptake to begin with regards to oral uptake. And so the concern is that that would diminish the uptake even further. I think, Tom, a better question is, why don't we just use plain buprenorphine sublingual tablets? And that I'm just talking not as a pharmacist, but as a student of our addictionologist who, the only argument for putting naloxone in with buprenorphine is to prevent illicit diversion. That's not what any of the literature demonstrates in Europe. So I hate to say it, but if Big Pharma can sell a pill for 3 cents or sell something or for 14 cents and sell something for $1.50, which one are they going to push? I mean, I've never even seen an ad or a mention of buprenorphine tablet, but that's actually on our agenda tomorrow. So Mercy Health, well, in our region, we actually have what's called the Opioid Dyad team, which is a multi-regional team. We do, I think we do Ashtabula, Trumbull, Columbiana, Mahoning, and counties, and we have all of our behavioral health teams on board with that one. That's on our subject tomorrow, because I asked the question, but our pharmacists provide me with the answer, and we do have Brian Latham, who's the chief pharmacy officer across our ministry, on tomorrow to talk about that. So I'll let you know more. I think it would be a great idea to check that out.
Yeah, that is very interesting. And I know Jessica asked, would regular fluoride treatments also help?
Absolutely. Yep. So in the frequency of which, so that individuals that actually are, again, now they're going to get 3 or 4 dental visits a year, not just 2. So at each of those visits, they get fluoride too. So we're going to, these folks are in dire need. So remember, the dental decay model, the take-home lesson here is it's remineralization, demineralization. So we know what's causing all the demineralization, the acidity, the bacteria. So we want to inundate, we want to supersede the rate at which they're achieving their goals by the rate at which we achieve ours. And so that's what's lots of fluoride. And yeah, fluoride is rat poison, but again, it's like the xylitol chewing gum. It takes a really lot of fluoride to poison a rat. So, and would take even more for us. Now, having said that, you got to keep it away from children, because their livers and kidneys aren't nearly as developed. Particularly,
as a dog lover, I'll say xylitol has to stay away from dogs as well.
Right, but I don't think they could eat chocolate either, right?
No, they cannot. No. David, I see you nodding your head a lot. Do you have any comments as leadership from the Opioid Consortium?
Well, I love this subject because, I come from a family of dentists. My father, grandfather, my brother's a periodontist in Lyndhurst. So, when patients get sober, whether it be from, alcohol, other drugs, opiates, and then decide they want to see a dentist and get their teeth fixed and get their dental problems addressed, it's a hugely impactful moment for me, because I feel like I'm, serving my own calling and my family's calling as well. So I really appreciate your presentation. I am going to forward it to my brother, the link.
Please.
And
forward this to everybody. We need to get the message out.
And he's a periodontist in Lyndhurst, so he does run a study group with Roger Hess, and I think they're both very passionate about this subject, and they're great allies to have. I just wanted to clarify, I guess, the pH problem is mainly attributable to the combination of buprenorphine with naloxone. It's not the formulation, that is the dual agent buprenorphine naloxone tablets are just as detrimental to the pH of the mouth as the film strips. That doesn't matter. It's the
Correct.
naloxone
Right.
presence. Is that
It's
right?
yes, sir.
Yeah. I think the main reason, at least in Ohio, why buprenorphine, the solo product is much less used is, unfortunately, there is a state medical board rule
Right.
about that. And I think that's one of the things that this group has tried and will continue to try to advocate for other options. And I've been in groups that have talked directly to the medical board leadership about my understanding is the relatively minimal impact of the dual agent on use of Suboxone, parenterally,
Right.
and that therefore the rule really doesn't have much beneficial impact. And this is
Right.
certainly one deleterious impact.
Right. Do you have any experience with buprenorphine only sublingual tablet?
Oh, yeah. I mean, I have some
Yeah.
folks who have had intolerances. That's the one thing in the medical board rule. If you can document an intolerance, then you can use the solo product. But I will tell you that even with that documented intolerance in my clinical notes, pharmacists don't want to fill it.
Okay. Yep. Understood. That's sometimes we get in our own way.
Yep.
So
Thank you very much.
You're welcome. And I'm if your brother's father, your family has anything to add, they might have a secret sauce that we haven't yet discovered. So please, we're all sharing and learning as we move forward on this.
Yeah, and David, that might be something we want to talk about in the policy subcommittee meeting as well. Might be something we want to write a letter of support for, or look into at least in the future. But are there any other questions specifically for Dr. Beck?
I would have a question and a bit of a comment. It's Sybil Marsh, and I cannot turn on my camera so you can see my face if you like.
Hi, Dr. Marsh.
I really appreciate that idea of training new providers, both medical and dental providers, to not be so siloed and to understand what each other is doing, and to participate as much as possible. My question is about the kind of dental situation that you see when that patient is an adult and now is coming to get buprenorphine naloxone therapy for their opioid use disorder. And it especially relates to growing up in a family where there's intergenerational substance use disorder. One of the things that we're trying to understand more in family medicine, where we see patients who often have difficulty adhering to a medication regimen or doing things to take care of themselves, is how many people are affected by adverse childhood experiences, and whether you think that affects people's dental health as they're growing up by either going to sugary foods for comfort, or is there something else that those patients bring to us when we start to see them for their buprenorphine therapy from a dental point of view?
That's a good question. And I actually think that you hit the nail on the head. I alluded to earlier the secondary factors in this, social determinants of health, generational addiction. Remember, generational addiction provides behavior habits that can be counterintuitive and productive to the healthy individual. My guess would be these individuals rarely have seen a dentist any time in their life. And the biggest challenge is that, and this is non-published data, this is anecdotal, but the biggest item is that if they do need a dental need, they'll present to the hospital emergency department because they don't even perceive that a dentist would be a good place to go because they're in pain at this point. They go to the hospital dental department, and what happens? Well, at our hospital, we have a 24/7 dental residency. And we're the only residency across Bonds Core Mercy Health. I mean, we're the 4th largest healthcare provider in the country, and we only have 1 dental presence. So what happens is they get an opioid and an antibiotic and the instruction that says, please go find a dentist. But if they are disingenuous in the reason for presenting to the ED, they get positive reinforcement. And so what we see is exactly what you're identifying. It's the behaviors, a multitude of behaviors that compound. It's associated in terms of health, but it's the diet, the lack of hygiene, it's the lack of regular dental care. And remember, they self-inoculate. And so, dental decay, we don't perceive it as it's infectious, contagious, and transmissible. So when the mom that's addicted is being a good mom and cleaning off her child's pacifier and inoculates it with her saliva and puts it in the child's mouth, now you've created an self-inoculation transmission. So it is infectious, contagious. And we've known that now because we have lots of studies and data now that child care is so preeminent in our society, and kids like their hands in their mouth, and you got a bunch of 2- and 3-year-olds sharing saliva. You have individuals that come in there with no history of dental decay and have a history of dental decay after the fact. Initially, we were blaming that on the diet. Oh, you're giving them fruit juices. Well, that might be true, but that's some great NIH work on that. But Sybil, your point is so well taken that we can, we're looking at dental. We want to try to make that little piece of the tip of the iceberg that we can address better. But the part of the iceberg that's underneath is big. The best thing I can tell you is we operate on children, well, mostly children, but we have patients that are such a bad dental distress. We have OR on Wednesdays and Fridays. So these people have such severe disease and such scope and distribution, they have to be put asleep. So we thought what would be a really good idea in nursing bottle caries in children, we thought it'd be really good to bring in the mother or caregiver of the child and do a pre-test on nutrition with the Youngstown State Nutrition people, do a presentation and a post-test, and then we wouldn't operate on them till the guardian or parent did that, because we had a high rate of return. 2 years later, no total neglect, no change in behaviors. We didn't affect the change in behavior, and so we attempted that, but of course, who was getting penalized in that strategy was not the parent, but the child. And in that realm, you're 100% right. We actually have what we call a 24-hour dental observation, meaning that we had one mother that the poor child was scheduled for 4 OR surgery visits. The mother never brought the child in. We had children's services involved. It just wasn't working. So we made up this, well, let's not call made up. Let's say we created this innovative solution where we had the child admitted for a 24-hour check so that the next morning the child got operated on. So you're 100% right. The challenges are, there's so many tentacles about this piece, but the celebration is that we do have recognition, opportunity, and lots of interventions that are simple to do.
All right. Well, thank you very much. I know we are coming up on time. We will be sending this presentation out. We'll send the link out to folks, and we also are going to put it on our YouTube channel, where you can also find our sex trafficking, the intersection of sex trafficking and opioid use disorder presentation, and then also our Igniting Compassion Fatigue documentary is also on that YouTube channel. And so please feel free to share that link. We'll be sending out Dr. Beck's bio. And then if people were to have follow-up questions for you, Dr. Beck, how can they
Please.
reach you?
Just send them my email and we'll answer up on that.
Perfect. Thank you so much. Well, with that,
Okay.
I think we're right on time. I want to say thank you again to everyone who attended today, and we'll see you in 2024.